guest athlete this evening. This is Steve Adams. Steve, you're a fairly elite athlete, aren't you? Can you tell us about what sort of sporting levels you've achieved?
I'm not sure elite is quite right. I'm a sort of an old age grouper, and for the last 8-9 years I've been in the GB squads age group level.
That sounds elite to me.
Yeah, and an Ironman, your greatest achievement there is 5th in the world or something, isn't that? Your age group?
I was 5th in the Europeans this year at half Ironman. I'm national champion at my age group currently.
So that's elite.
Not elite at all, really, is it?
So I would do a pretty standard physical therapy assessment. First of all, I would do a sort of mobility test, and then we'll look at looking at some muscle testing as well. So I would take a good look at his general posture. One thing to note which stands out is this slight winging of the scapula and the rotation forward of this right shoulder. And I know, talking to him earlier, that he does get some impingement post swimming, particularly freestyle. A day or so after event, you get some long head of the bicep and supraspinatus tendinopathy. So that sort of stands out. And he's got a little bit of a slightly bow-legged there, but very serves him well. Right, so what I would do initially is an assessment of the spine. So I'll get you to lean to your left side, and then down to the right. We're looking at the lumbar spine. And then I get you to lean backwards and straighten up. And I get you to bring the left knee up towards your chest. Okay, and down. Now the right one. Okay, great. And then I get you to put your arms out in front of you and then rotate round to the left. We're looking particularly at thoracic spine. As a swimmer, you want to have good mobility through this thoracic area, and then round to the right and straighten up. Because you have coupled motion between the thoracic spine and the shoulder when you're swimming, if you let your arms down. And as the shoulder is rotating through in the swimming stroke, the thoracic spine is going to rotate in the opposite direction. So if you have a lot of stiffness in the thoracic spine, you often see that in recreational swimmers spending all week in the office. The shoulder sits forward, and this is stiff, and then it sets them up for impingement syndrome.
Is that specific?
Right, while you're standing, we just do an assessment of your muscle balance. So I'm going to get you to get this pole here, and then get you to hold that above your shoulders at shoulder's width. And I just want you to do a few half squats for me, and then we'll do some deeper squats. So what we're looking here tells you a little bit about the how tight the calf muscles are, how much dorsiflexion is able to perform. And also the trunk's flexing forward, so it looks as though there's going to be quite a lot of tension in the hip flexor muscles, and maybe a little bit of glute weakness. Okay, we'll take that from you. So I'm going to get you standing on your left leg now, and then with your arms out in front of you, do a few half squats. Okay, so we're seeing...
That's not so successful, is it?
Okay, well, he has been on a watt bike earlier. To give him his... And then switch legs around. So this tells you a lot about the neuroproprioception and the ability to control, and that's obviously there's quite a lot of collapsing in. Steve does do a lot of cross-training in the reformer work with Pilates, so that is, that's something that you're continually working on.
When you say, what sort of bike did you say Steve had been on earlier on?
You were on a watt bike earlier, weren't you?
Yeah, Nathan.
Yeah.
What's one of those?
It's a bike which predominantly measures your watt output, hence the name of the bike. But these days it measures a whole series of things in terms of the amount of load you put on each of the pedals, the rotation of the pedals.
So this is a high-tech piece of static bike.
Yeah, quite a lot of gyms have watt bikes in them as well.
Yeah, and this one's specifically designed for triathletes.
Yeah, okay, that's great. So if you turn and face me, we'll do a few little lunges. So with your arms above your head, and then again going into this forward position. And what we're looking at is to see if you do that once more on this one. Okay, drop down. We're looking at how much deviation there is, and come up again, that's good. And switch legs around. It just gives you sorry, you should go into a sort of proper lunge, that's it. Go back to where you were, and then kind of drop forward. That's it, perfect. A bit more, that's it. So we're looking at the ability to control being in a neutral position. Ideally, the patella should be between the first and second metatarsal. He's dropping in a little bit on both sides, actually. So if I get you to come and sit onto the table, first of all, We're just going to test the hip flexor. So I'm just going to get you to put your arms behind your back. And I'm just going to get you to bring your left knee up towards your chest. And I'm just looking at the ability to maintain your lordosis. And you do drop slightly into a flex position. And then same on the other one. That's good. Okay, and down. So that gives you some idea of the ability.
So what would you see? Would you see it flattening out in...
there's a slight flattening out. So there's probably a little bit of hip flexor tightness and some hip flexor weakness. And in someone who had perfect control, their lordosis will be maintained equally. Yeah. It's not actually bad because Steve is doing cross-training, he is doing reformer Pilates, so he's probably addressing some of those things. Actually, while you're in that position, I would also try and test the power individually as well. So you keep your arms folded. I'm just going to push down, just gives me some idea whether you tilt laterally at all. That's good. Actually, that's good. So I can tell
which
you
way is he going to tilt and what will that indicate?
Well, if I'm pushing down and he tilts that way, he's compensating for a lack of power. So that if your ability to maintain the trunk is, if you're perfectly upright and there's good resistance, then there's good engagement, good recruitment. And then we move into a modified Thomas test. So I get you to sit right on the end, and then I put the pillow under your head and lie back. I get you to bring the left knee up towards your chest. And we're just looking here for whether the knee sits below the ASAS on the pelvis. If it were up here, we'd know there was tightness in the hip flexor. And if we'd bend the knee, that would just bend the knee for me, bend that knee, and let it drop down. Yeah, so we'll see a bit of tension in the rectus femoris. So that helps us to differentiate. And then we switch around. Same on this one. And on this one, the hip flexor actually isn't too tight. If you bend the knee, it's not as tight as the other side. There is a little bit of lateral shift, so there's probably a little bit of tightness down the iliotibial band on this side. Okay, and if I get you to come and hop up a second, and I'll get you lying face down. And this is a fairly subjective test, but it does give you some idea of glute recruitment. So I'm testing the glute maximus and the hamstring. The bigger muscle should engage first, so we should see the gluteal muscle contract before the hamstring. So I get you to lift this leg off, Steve. That's pretty good. And down. The problem with this is it is very subjective. You get 10 people getting 10 different answers. And again, it just gives you some idea. That's good. And down. And then same on this one. Okay, this is slightly down. He actually has been working quite hard on this. So in a lot of recreational athletes, you really see the hamstring tensing up quite considerably before the gluteal muscle
so
engages.
how do you address that though? Because lots of people talk about activation times the muscles, but how do you actually retrain the muscle?
Well, then you'd start doing some individual glute work. Now, there's the hundreds of exercises out there, ranging from cable systems where you're standing on one leg. It's better to do them with balance as well, and then you've got bands. You can do the crab walks.
How does that address the firing pattern though? Because that will make the glutes stronger, but does it also at the same time retrain them to fire earlier?
Well, then you'd try and do co-activation. So if you did bridges, for example, then you're working the hamstring and the gluteal muscles in unison. So you'd start incorporating co-active exercises. So you're not just, you start off isolating it and then you build in more complex exercises. Yeah. Okay, and then while you're in this position, we can then do the glute maximus test. So I get you to lift the leg up and I'm going to push down and look for the resistance. Okay, that's good. We'll do the same on this side. Lift up. Good, great. And then I'll get you lying on your side and we'll test now glute medius and minimus. Okay, so in this position, we'll bend this knee up. We'll have that leg just about there. Okay, that's good. I'm testing the anterior fibers now of glute medius, so I'm going to get you to just push up against me. Okay, that's good. Again, it just gives you a rough idea. We don't know what happens when you reach fatigue. So if you wanted to be really accurate, you just do this over and over, lots of repetitions, and then forget posterior. We go to here, and then same thing, just push up. And that is slightly, okay, that's good.
Slightly?
It felt slightly, initially a little bit weaker, but you quickly engaged that, so that's fine. And I'll get you lying onto your back. And if you wanted, again, to do a little test to see how well he's activating his glute, we'd get him basically do a bridge movement. So lifting up, lift your bottom off the table, and then I'll try and get you to lift one leg up. Bend the knee up and hold it there. And just try and hold that position. And what you're looking for here is the ability to maintain stable person. I can tell he's been doing quite a lot of work on this. You've done quite a lot of training, haven't you, on this, and then switch legs around.
Are you finding that at all challenging doing that, Steve?
Not this one.
No, he's been doing this on machines, so he's not had any problems with that. That's good. Okay, and then down. We could also test, another way of testing glute medius is to, in this position with the calf slightly off the table, I get you to try and push your feet apart. That's it. Good. Again, people who have got obvious weakness, they really struggle with that one. And again, Steve is pretty good at that. Because we also want to have a look at his scapular control, can I get you to stand up for me a moment? And then get you to come and stand over the wall here. We're going to look at a fairly simple test to see how your subscapular and trapezius muscle, whether the lower and intermediate fibers are working properly. So if we start off with this, we're just going to do a one-arm press-up. So we do it with the left one first. And I want you to sort of lean, feet slightly further back. I want you to lean forwards and try and, that's it, good. And come up again, and once more, good. And then switch around. We're just looking for any obvious differences. That's good. Does one of those does one feel more difficult than the other, or?
No, not really.
Not too bad. Okay, we can put it slightly further out. That's it. Do it again. The further out we have it, the more we're testing the pectoral muscle. If you want to also prove it and further in, check the tricep, and then again. And you've had some little bit of issues with impingement on the shoulder, so that scapular control is probably not quite as good as the other side. Just going through the mobility tests, having done a standing assessment, we'd now look at going through the whole joint kinetic chain. So I'd start off with a subtalar, checking the subtalar joint on each ankle, seeing if there's any joint restrictions, and we go through all the individual articulations in both feet. I then move up into the knee, and a joint that often gets neglected is the upper proximal tib-fib joint, which is quite an important joint for distributing load. So I would, if it was stiff, I'd try and work on some soft tissue and manual therapies to try and release that and test it on each side. Mm-hmm. And same on this one. That's often, this is actually quite tight. Does anyone work on that for you?
Not recently, no.
You've had work on that in the past, I suspect.
Calf muscle,
Yeah. Okay, and then we move into the knee joint. Just do the Apley and McMurray tests, check for any meniscal pain, and then check patellofemoral. So it's a standard sort of physical therapy assessment, which we're all aware of. And then we look at the hip, putting it in various positions of flexion, internal rotation, and then the Faber test to see if there's any signs of femoral acetabular impingement or any hip pathology. Do the same on the other side. And then working up to the upper thoracic area. Can I get you to put your fingers together behind your neck? If I take the pillow away, actually you're quite good. Most people who are sat at desks computers have the shoulders coming right forwards because there's so much shortening in the pectoral muscles. That's good. So that just give you an idea of that. Pop that under there. Let your arms down. And then we do again at the beginning just a shoulder assessment, checking for range of movement, internal rotation, external rotation. Do the standard sort of tests. And then into the cervical spine. So again, because he swims freestyle, I just make sure there's a good range of. Do you breathe both ways?
Yeah.
That's good. If you're able to breathe both ways, that certainly improves the biomechanics of your swimming style. Because if you're always breathing to one side, that does develop muscle asymmetries and muscle imbalances. So, in good condition.
So now you've done a full screening test of Steve here. Is that would you do that just on every athlete who comes in, or is that you just demonstrating the range of things that you would go through?
Because it doesn't take very long to go from, to do the whole thing. You can do the whole thing in probably 10 minutes, 15 minutes.
Yeah.
So I would do that as a sort of standard assessment, with joint assessment, and you get a functional test. I mean, there's plenty of literature on I didn't do many complex functional tests. You can add all sorts of things. If you know your anatomy, you can really sort of make up a lot of the stuff. You can add a whole variety of different things. It just gives you an overview of how everything is fitting together. And for example, I had a rower that kept having injections into lateral epicondylitis and a problem, and no one was looking at the biomechanics of it. And I got her coach to send me video of her towards the end of a race, and we could see her shoulder was dropping forward in the last sort of couple of hundred meters. And that whole scapular control was the reason she was getting this kind of kinetic chain effect. Yeah. So, she was on a program, cross-training, and it sorted the problem out. So you see this, particularly with patellofemoral problems, where you're getting tracking problems. If you're correcting the mechanics further away from the site generating pain, you can often improve the condition. So the problem is that I think, and as physical therapists, we're in a good position to do that. We can have a more holistic overview. My having worked with a lot of, or continuing to work with a lot of consultants, they're inevitably quite reductionist, and they will use some sort of intervention to work on the problem locally. And it's quite interesting doing talks to surgeons, and some of them really are quite surprised. They've never been taught that kind of connection of how things all interconnect. So I think we are in a good, unique position as physical therapists to be able to do that.